Today, the last topic of our discussion is clinical reasoning. These are the objectives for this lecture. Outline for the session: review the definition of clinical reasoning, exercise and diagnosis, examine the theoretical models of clinical reasoning, focus on reasoning for diagnosis, review some of the lessons learned in CR research, discuss how you might take this back to the clinic with you. It is more like a practical practice. First, we will talk about the clinical reasoning definition. The thinking or decision-making process that are used in clinical practice. The goal is wise action. What happens is when you are actually in the practical field, sometimes you have to take instant wise decision to help the patient or to save the patient. So every time your bookish knowledge is not being practical, and every time you cannot be opening your books all the time. So sometimes you have to follow your intuition, your past experience, your learning process, your practical guidance. So this all basically encompass clinical reasoning. It is more practical view of work. Others have also defined clinical reasoning like it refers to a process in which the therapist interacting with the patient structures, meaning, goals and health management strategies based on clinical data, client choices, professional judgment and knowledge. The way I explained to you, everything is encompassed in this definition. Everything is included in this definition. Hypothesis oriented, collaborative and reflective. Sometimes you have to generate a hypothesis that what could be the reason of this symptom, what could be the main cause of this symptom, and then you have to practically test it. You have to go for the collaborative decision, okay, with the help of others, and then you also have to do reflective thinking, thinking about your thinking. Knowledge and organization of knowledge are important, okay. First your own knowledge and then organization of various other forms of knowledge is important for clinical reasoning. Process of clinical reasoning. Theoretical models of reasoning, clinical reasoning, there are 4 models. First is knowledge based, knowledge reasoning integration. Second, integrated patient-centered model. Third, hypothetico-deductive, and fourth, pattern recognition. Knowledge, reasoning integration. Clinical reasoning is not separate skill from knowledge and clinical skills. It is not, clinical reasoning is not something completely separate. It is part and parcel of your knowledge and your clinical skills which you had been trained for and which you had been practicing. It comes along with your regular knowledge and your regular clinical skills. Important for knowledge to be domain specific. Obviously, in whatever area you are working, your knowledge should be domain specific. You have to be proficient in your own particular area. With increasing knowledge and reasoning skills, knowledge structure changes towards illness scripts. You have to increase your knowledge, your reasoning skill that will help you to identify the illness for which you are working for. Okay, your knowledge structure basically changes and improves with time. Developing expertise. Knowledge acquisition and clinical reasoning go hand in hand. Your knowledge acquisition, how you are acquiring knowledge and how you are collaborating it with your clinical reasoning, they both go hand in hand, side by side. Occurs in stages, okay. First you are new, you are novice, then your experience become intermediate level experience, and after a lot of experience you become an expert. So this acquisition of knowledge in clinical reasoning occurs in stages. First you are novice, then you are intermediate, and then you become expert. So developing expertise, how it moves on. If you see in this chart, there are three columns: level, knowledge representation, and knowledge structure. Your level, when you are new, you are a novice. Knowledge representation, networks. Okay, you network with other people and you learn. Knowledge structure, knowledge growth and validation. Slowly and gradually your knowledge keeps on growing and you validate. Okay, you do the correct, right judgment, whatever is required. Interim level, intermediate level, okay, again there is networking. And encapsulation, you identify the specific thing which needs the attention, because now your experience level is that of intermediate level. When you are an expert, illness scripts, illness script formation, instantiated scripts. That means you have enough information, enough experience where you can identify something very quickly, and you also know how to relate it to some previous experience or some previous case which you had encountered before. This can happen only when you are expert, when you have a lot of experience in your field. Then we will discuss about level, clinical reasoning, control required, and demand. Okay, a novice, long chains of detailed reasoning. Okay, he needs a lot of reasoning because he's not an expert, he's in the learning process. Control required, active monitoring of each step. When a new person, a novice health professional person is working, the seniors or whoever is in charge needs constant monitoring. Okay, the demand is very, the demand of, you can say, the control is very high. Then at the interim level, that is the intermediate level, reasoning through encapsulated network, where you can identify the exact thing which needs the attention because you have at least intermediate level of experience, but still you require some networking, some guidance from the senior. Active monitoring each step. How do you require to be monitoring at each step? Yes, you are required, but at a medium level, not at a high level like for the novice. Expert, illness script activation and instantiation, okay, where you can identify the exact problem, you can relate it with some past experience, some past case. Monitoring at a level of script, over here the monitoring requirement is low. Why? Because the person is already an expert. Integrated patient-centered model involves three core elements: knowledge level, cognition level, and metacognition. Incorporates mutual decision-making process with the patient, contextual interaction, situation, and environment. Over here, the healthcare professional is interacting with the patient. So it is integrated patient-centered model where the professional and the patient should work in collaboration with mutual decision making. They both should participate in the decision, and they should also consider the situation and the environment. Whatever the patient has gone through, it has to be considered. Knowledge can be based on biomedical knowledge, clinical knowledge, and everyday knowledge. These three parameters are included in the part of the knowledge. Biomedical knowledge is simply your bookish things, okay. Clinical knowledge, whatever is practically you are doing. Everyday knowledge is basically from the environment point of view, from the patient's background point of view. Increased growth of knowledge needs to be organized to be useful. It has to be organized so that you can actually properly understand it to take the right decision. Then cognition, perception of relevant from irrelevant information. When a patient comes to you, they tell you a lot of things. So you have to extract the relevant things. Interpretation of information and hypothesis testing. Inquiry strategies. If you have made a hypothesis, you have to make some inquiry related to that hypothesis. Maybe you have made a hypothesis that this person is suffering from frequent flu because of certain things lacking in his diet. Okay. So, but you have to make the right inquiry to confirm your hypothesis. Weighing and synthesis of information. Okay, then take a balance. Okay, whatever you are doing in the right way or not. Metacognition is therapist's awareness, self-monitoring and reflective process. Thinking about your thinking, being aware about your own internal thinking. What you are doing, is it right, is it wrong, is it helping the patient, it is making you go in the right direction, or you are showing some kind of biases. Reflection, to be conscious that you are ignorant is a great step to knowledge. Okay, sometimes to think yourself as an ignorant person makes you more motivated to search for something extra. Okay, so if we think that no, we know everything, we are genius, okay, I can never go wrong, then we would not be making an effort to improve ourselves. So that is why they are saying that in reflection, if you take yourself as somebody who keeps on learning, you keep on doing the right thing. Narrative reasoning, understanding the patient's illness experience, their stories, meaning, perspectives, context, beliefs and cultures. Understanding everything from the patient's point of view. Whatever story he is narrating to you, try to understand what it's meant to him. Try to understand from his contextual point of view, from his belief point of view, from the culture where he is coming from. Using narrative reasoning, patient wants to return to his job because he cannot afford to stay at home for long since he has got a family to feed. Shows up for all clinical appointments and does everything that is asked of him during the appointment. He is regular for his appointment because he wants to get better. Does not get around to doing the exercises at home. Without exercises, treatment will not be successful. Okay, there is one thing which is lacking. Okay, he is not getting around to do the exercise which he has been asked to do at home. So how you should proceed, how you should question, what could be the reason behind this, how he should avoid doing it to improve himself. Okay, integrated patient-centered model. In integrated patient-centered model, all these elements have to be integrated. The client's input, the environment from where he's coming, knowledge, the clinical problem, the actual symptoms which are there, the cognition, and obviously the metacognition. So it is the complete combination of all these elements which will help in the care of the patient. Integrated patient-centered model further explained here how you can come up with the final outcome. First, the clinical reasoning elements should include first there is initial encounter with the client. Okay, the first time when the client comes to you, and then the clinical reasoning elements will be based on cognition, metacognition, the clinical problem, the symptoms which he is showing, knowledge which you can apply, the environment, feedback, and the client's input. Okay, so all together, growing understanding of the client and the clinical problem which will help you to come up with the final outcome. Hypothetico-deductive reasoning, a process of generating a limited number of hypotheses early in the encounter and using them to guide the subsequent data collection. Like I told you in the initial beginning, when the client comes to you, you sometimes generate hypotheses. Okay, what could be the reason behind this problem? And then when you have got a hypothesis, you inquire further information in relation to that hypothesis so that you can come up with the right decision. Analytic process of reasoning, backward reasoning, relation between the signs and symptoms and diagnosis. Okay, backward reasoning, the signs and symptoms which the patient is showing now, what could be the history behind those signs and symptoms, and how your backward reasoning will help you to come up with the current diagnosis. Hypothesis generating and testing involves both inductive and deductive reasoning. induction to generate the hypothesis, okay. That is something in general was told to you, and now you are going towards something specific, that is inductive reasoning, okay. You are generating a hypothesis from so much of information towards something one or two. Deductive reasoning to test the hypothesis, okay. Now you have to confirm your hypothesis, okay, so that you can overall form the diagnosis. For that, obviously, you have to go for some testing. You have to ask certain questions. Sometimes you have to refer the patient towards certain kind of analysis, testing, x-rays, different types of blood tests, or anything which is required. That would be in the deductive reasoning. Hypothetico-deductive reasoning, its pros and cons. Positives are the pros, it's thorough, but negative side is it can be slow. Positive side, it is organized and appears to be a skill that can be taught to novice clinicians, the new clinicians who are new in this profession. Negative side, too much data can leave reasoner without a direction. If you are new, sometimes too much of reasons doesn't help you in which direction to go to, until and unless you take some expert advice. Collaborative reasoning. Shared decision making between the therapist and the client. Client's opinions actively sought and utilized. Here you have to make a decision along with the client input. Okay, and the client is actively asked to give his opinions, to answer certain questions to help in the final diagnosis. This is a chart which you can see that from the collaborative clinical reasoning process point of view, from the patient side, what are the things which can help you out, and what are the things from the therapist side which can help you out to final diagnosis. Okay, so you can read this chart thoroughly for understanding. Pattern recognition. Direct automatic retrieval of information from a well-organized knowledge base, seeing a case that strongly resembles a case seen in the past. This thing comes at an expert level, where you see something and it strongly resembles to something which you had seen previously. Okay, this is the pattern recognition. You are recognizing the pattern, okay, of the disease which you had encountered before. Non-analytic process of reasoning. It is non-analytic. It is forward reasoning. Because of something which you had encountered before, you can assume that this is the same thing and you can move forward. Illness scripts, the previous detailed analysis of the previous cases, the scripts would be there, the written reports would be there. It is more or less intuition as well. Intuition, like your sixth sense, something, a bulb which suddenly switches on in your mind, tends to occur unconsciously. It is not happening consciously, but sometimes it is happening unconsciously. You know, sometimes when you see something, it automatically triggers something in your mind, and then you instantly recognize a similar pattern, okay, and then you start working on it. Okay, now the pros and cons of pattern recognition. The positive can be it is very fast. Negative side, it lacks certainty because it can be intuitive. The second positive point, conclusions can be reached with imprecise data. Okay, negative side, need exposure to pattern in order to recognize. Okay, basically you need a lot of expertise level to go for this kind of clinical reasoning. If you are not an expert, you can make a lot of mistakes. Okay, now we come to the point where some practical advices would be given, like what we know about how students use these models. Okay, here they have used some abbreviations without writing their full form first. Like PT is physical therapy students. Okay, so they are saying that physical therapy students do not use the model effectively on first clinical placements. Okay, HD is not clear to me. What do they meant by HD? Physical therapy students perceive that they use it automatically. Less than half of the students based decisions on clients' specific concerns. Students felt that they made good decisions. Okay, they are saying that the students who practice physical therapy, so less than half of the students are basically emphasizing on the client's specific concern. Their decisions are not always based on the specific concerns of the patients. Less than half of the students are doing it, but still they feel that whatever decisions they have made is good enough. On the other hand, while using the PBL sessions, the occupational therapy students perceived improvement in clinical skills, clinical reasoning skills. In what way they have perceived the improvements? In identifying assumptions, developing hypotheses, comparing and contrasting options, contemplating what if scenario. Okay, using the PBL sessions, they can easily learn to identify what is specific thing which they should pay attention to, how to develop the hypothesis, how to do the comparison analysis. Okay, comparing and contrasting options. Okay, comparing to something else and contrasting to something else. What does this mean? And contemplating what if scenario, what if this thing happens, what it will lead to. So this kind of discussion helps the occupational therapist students to improve their clinical reasoning skills. Then what we know about accuracy of these methods. HD and pattern recognition have equally poor diagnostic accuracies in novices. Again, this HD is not clear, and I don't know why they have written the abbreviation without highlighting the exact form. Okay, but what they are saying that this is not very much accurate in case of the novices, the health professional people who are new in the practical field. Combined strategies improve the accuracy of the diagnosis. That means that whatever strategies we have been talking about so far about the clinical reasoning, if you use them in combination and not emphasizing only on any one, but using them in combination will help you in the accuracy of the diagnosis. When instructed to use combined methods of reasoning and compare and contrast methods, further improved accuracy was noted. Like I said, when you are using in combination with all the different methods of clinical reasoning, you will have better accuracy. What do we know about clinical practice and clinical reasoning? Students need to feel safe because they are still students, they are not experts. Okay, so they are students, so they are not experts, so they need to feel safe. Role of reflection is important. Reflection takes time. Modeling reflection can be valuable reflection tools. Okay, it's important that you should learn to reflect. Take time, sit in isolation and think about your thinking. Okay, and try to come up with the tools, solutions to improve your self and your working strategy. Model of practice supervision may influence reasoning demonstrated by the student. Influence of two therapists, influence of other students, peer consultations. When you are a student, you need others' guidance. Okay, your seniors, supervisors, or your therapist and the fellow students can be consulted to improve your clinical reasoning skills. The take-home message is clinical reasoning is a complex, individualized process. Everyone can have an individual style of clinical reasoning. Students should use multiple strategies of clinical reasoning for improved accuracy. Use different strategies. Do not stick to any one. Students should compare and contrast patterns for further higher diagnostic accuracy. Okay, use the compare and contrast patterns to improve the diagnostic accuracy in your work. Clinical reasoning, as defined by some of the experts, there is no such thing as clinical reasoning. There is no one best way through the problem. So you can try various things till the time you become an expert. These are the reference list.